Okay. So I can't encourage you guys enough to go into Moodle often. And I don't want to overwhelm you. I do have a tendency to like to put resources in Moodle. And so some of them are like, you kind of have to know where they are. You have to look at them. And then others are just nice to know. So I have tried to streamline it, and some of this stuff is hidden from you and you can't see it. So you're just looking at my view here. But for example, this is this week. Well, let's look back at last week, actually, because last week we couldn't get through the lecture. Today, I'm pretty sure we'll get through the lecture because it's just one picture after another. I don't have to explain like a concept. So we're just like looking at anatomy. So that should go pretty quickly. But for example, last week, we couldn't get through the whole lecture. And so I have these from last year, and they're all segmented into short videos, because it's really hard to sit and listen to somebody kind of drone on for an hour and a half or 2 hours, and everybody zones out after 20 minutes. It doesn't matter how dynamic of a speaker you are, everybody drowns out. And I'm certainly probably not that dynamic anyways, but it's just fact. So I chunk them up. So you look at this and you're just like, oh my gosh, how many videos am I going to have to watch? But that's why I put here, and I put 22 minutes, 9 minutes, 21 minutes, 10 minutes. So it's just look at it and see what's there. Don't just let it overwhelm you and shut you down and just be like, I'm not, or forget about it entirely. Don't forget about it entirely. These are from last year. I'm not in love with them, but because we ran short on time, I was glad that I at least have them for you guys. So you absolutely have to watch them if you want to get a better sense of like panos and identifying errors. You just have to. We don't have any time to lecture on it other than what's recorded. Then there's this partial lecture from last week of what we were able to get through. I have a lecture guide for you. Follow along with the lecture guide and the PowerPoint. There's the regular PowerPoint, and then there's two panel points. There's two PowerPoints on pano. One is mostly anatomy and technique. The other one, I believe, is errors. So use these PowerPoints, use these videos. And then here I have some just extra stuff. So nothing needs to be turned in. This is all just for helping you. This is a really good video that Director Copeland did when she taught it. It's a landmark video. It goes over all the landmarks that you have to know, all the ones we were talking about in lab. So that's just another video you can watch. Placement, error, demo for pano. This is, I think, just a little bit quick video. Ghost image video, it's just like a 4-minute video on ghost images. Let me go down. This is just your instructions, which you all got in lab on how to take a pano. So it's just your instructions. It's there if you need it. You don't, it's not a big deal. I hid that because we don't need that. FMX for classroom. And then this is just stuff that we did last week with the FMX in classroom. So I just wanted to highlight that if anyone's sitting there going, well, she didn't finish the lecture, is she going to actually ever lecture on that? The answer is no. I'm sorry. I really wish that I had more time in class. You guys might not wish that we had more time in class, but that's just the reality of it. And so you have to just take it on yourself and find the time in the week. I know that sounds horrible because everyone's like, where's the time? But you do have to find it somewhere to watch those videos. So today, this is week 8. So what we have here is these are videos that I left on from last year. Again, don't love them, but they're there. So there's 3 of them, 11 minutes, 20 minutes, 16 minutes, but we will get through the lecture today. Another lecture guide for this content. So use those to help you guys learn the material and for tests. Here's the PowerPoint. There's the 2 PowerPoints. They're the same. One has like a key, I guess, and one doesn't, but it's the same PowerPoint. I don't know if this Quizlet works, but it's there if you need it. Panel landmark practice, identifying the landmark. So here's just some more practice stuff that has to do with Pano. Nothing you have to do, but they're just worksheets. Analysis of errors. I actually think that this is all stuff that we did in lab. So click on it just to see, but don't, you know, and if it's nothing you have to worry about, it's nothing. So Panos for analysis of errors, that's stuff we did in lab. I could even hide that. Another Pano for practice. So there's just Panos for practice there. So that's what we have in this week. This is kind of fun. I'll just show you real quick. Locate the condyle, mandibular notch, which can also be called the sigmoid notch. If anyone gets confused and sees that written somewhere, it can be the sigmoid or the mandibular. So where's the condyle? Right where I'm clicking. Look, it's a check mark. No, so this is the only thing. Don't let it confuse you. I might have only, this was an activity I was messing with last year on how to create. And this is the condyle, even though it has an X. So obviously I didn't select both, which I should have. So don't let that throw you. And then the mandibular notch. Where's the mandibular notch? There's the mandibular notch. Well, that's also the mandibular notch, but clearly I only picked one side. Where's the orbit? There's the orbit, and so on. So it's just a practice fun thing. I just was messing around with the different kinds of activities to create, and I made that last year. So anyways, okay, let's move on. Anybody have any questions at all? Yeah. So there's going to be there's question. Did you guys see the study guide? So there's going to be everything that's on that study guide is what. So you might notice that there's some dental materials. There's not going to be any PA anatomy. So what we're talking about today, but there is going to be dental materials. So I kind of tried to just almost write it down because it might be a little jumpy. So like there is biology, dental characteristics, contrast, that kind of stuff, dental materials, and then Pano errors. So that's the stuff. The stuff on the study guide, study that. That's what you need to study. It's harder for me to say week this, week that, because like there is some for week 9, but it's not all of week 9. So that's why I just wanted to give you like the topics, like dental materials is going to be on there. Okay. So I am going to bring this back over here. Why can't I get it over? And then we'll get the PowerPoint up here. Oh, and I'm not going to talk about it today because I just think it's too much. However, I'm just going to plant this little seed in your brains that we are at almost at the end of week 8, right? Am I saying that right? Yes. Okay, we're almost at the end of week 8, and in a very short period of time, you guys will have a live patient. So I'm not going to go through all the stuff that to kind of prime you for it, because I just think it's too much and you've probably had enough today, but start thinking about it. If you haven't already, you need to start thinking about who your patient is going to be. And if you feel like, I don't know who my patient's going to be, start talking to friends, because it's going to come fast. Just one, but they have to need an FMX. Like they can't have had an FMX a year ago. And yeah, it can be 3 years. If it needs to be 3 years, or say some kind of a wackadoo situation where maybe they moved, they had an FMX at a dentist in Iowa. Maybe it was 2 years ago, but maybe they're high risk, and it's, something like that could possibly work. But in general, they need at least 3 years. Brandon? Our live patients are week 14 and 15. So it's Thanksgiving, week 13, and then week 14 and 15. So it's the last week of November and the first week of December, I believe. And we got to get a bunch of information. They got to get scheduled through the front desk. Like there's several things that we got to do and talk about. So I'm not going to go over it today because I'll do it next week, but just planting that seed. Yeah. No, I know. Yes, Nikki. No. They have to be an adult. Yeah. Oh, man. I don't know. So they're not accepting unvaccinated patients? Okay, so all right, I'm going to, but feel free you guys to stop by, email me. I'll go over all the details a little bit more next week because we kind of got to get into the weeds on it and talk about it. But I did just want to remind you, like, oh yeah, that's happening. We're gonna think about that too. Okay, so let me get this back up. Okay, so now this week we're going to talk about the anatomy that you see on PAs. And this is nice because you guys already know how to take PAs. You generally are getting familiar with what they look like. So now we're just naming structures that we see in them. So this should be, you know, hopefully a pretty good lecture, I think. It's kind of a fun one. There's a lot of slides here, but like I said, a lot of this material is not brand new at all. So let's see, it's 120 and we go till 250, right? So let's take a break in like 45 minutes or 40 minutes. We'll take a need to set an alarm or else. Okay, so we're going to identify normal anatomy and landmarks in these intraoral films. We're going to name the typical anatomic landmarks expected to see on the films, identify different types of dental materials. We'll do that at the end. Okay, so if we're looking at a maxillary central incisor, some of the normal stuff that you should expect to see is going to be the nasal septum, which goes all the way up. There's just a straight long septum in between the nasal fossa. You're going to see the nasal fossa, which is going to be a radiolucent area. You're going to see the, oh yeah. I am recording. Yes, thank you for checking. I appreciate that a lot. And then you're going to see radiopaque area down at the base of the navel septum, which is the anterior nasal spine. FYI, when you guys do the landmark exam, if you don't say anterior nasal spine and you just say nasal spine, you still get the point. So it's just, you know, for that little info. Incisive foramen is a thinned out area in the bone, and so it looks more radiolucent. And then the median palatine suture runs through between the central incisors up to the anterior nasal spine. Sometimes you only see it like at the very end, way down here. Sometimes you only see it and it gets obscured through here. Sometimes you can see it all the way up. It just depends on the x-ray. Sometimes you can't see it at all. Sometimes their suture is so tight you can't see it. But that's, and all of these are that way. Some things you just see better than others. But it will look like a radiolucent line down through the central incisors. Sometimes you can see the outline of the soft tissue of the nose, and it generally is over the roots of the maxillary central incisors, but it can be at different heights because people have different shaped noses and different sized noses, and also the XEP can be at different vertical angulations. So the nose, the soft tissue of the nose can look in different areas, but in general, it's over the roots. And then sometimes you can pick up the soft tissue of the upper lip, And that is generally over more like the crowns of the central incisors. So here is a bone skull image of the septum. I always want to call the septum the spine. I don't know when it'll get out of my brain, but the septum through the center, the spine at the end, and then we have the cavernous area as the fossa, the nasal fossa. And over here on the skull, you can see the suture down through the middle, and then sort of a little scooped out area on the palatal surface, which is the incisive foramen. And here again, you can see the septum skull, and then next to it, you can see the septum radiograph. And you'd have down here, yeah. It was pointing at the suture. This one, if it was pointing at the suture, that you'd have an arrow, probably a couple arrows that were pointing right through here. Can you see the suture here? Right through. It's hard to see it. That's not a great picture for the suture, but I can see the suture, so I guess it could be used for that. But usually I try and get an image that it really jumps out, whatever it is that I'm asking you to see. You can see the fossa on either side because it's radio lucent, and then the anterior spine would be down here. On the skull, on the radiograph. At any point I'm going too fast, just tell me. Spine on the skull, and like the little triangular end, the spine on the radiograph. And you can kind of see the suture a little bit through there. You lose it in the middle, and then you can pick it up again a little bit through. You can also see the concha, but a lot of times I don't think that's on any test that you have, but the concha is a little bit, you can see it on the skull here and here. This is the nasal concha, and you can kind of pick it up. It usually looks a little bit like not as radiopaque as bone, not as radiolucent as a fossa, but just that mid-gray tone. But that sometimes is pointed out on some of the worksheets, but it's not on any exam. Yeah, you guys wanna, if you're by light switch, can you just shut them all the way down? Because we're gonna look at a lot of, oh boy. Still bright. Yeah, if you want to. Do you have, and you have yours all the way down? I don't know how that one gets turned on. Maybe they're like security lights. Yeah, I hope it's dark enough for you guys. Okay, so then we have over here the kind of scooped out area, incisive foramen, and then the incisive foramen. And see how there's lots of arrows pointing to it? So if this was asking you about the incisive median palatine suture, the arrows would not be going around, they would be going up against it. So if I'm asking you about a structure that is close to another structure, I'm going to make sure that I'm like letting you know I'm asking you about this, not this. You know what I mean? Like it's going to be more obvious because the arrows are going to border it. So just remember that this, even though you could imagine you're pointing to the suture, if I was pointing to the suture, the arrows would be more in the center here. So this is pointing to the incisive foramen. Like this. See how the arrows are pointing to this, the mid. So the median palatine suture on either side. This has a very small foramen. Right through here is the foramen, but it's very small compared to the. And then this is an example of soft tissue of the nose. So it kind of comes down like right at the CJ, pretty much, like right to the central incisor. And it would be hard to see unless you knew to kind of squint your eyes and look sideways and go, oh yeah, that's a nose. It just changes the contrast a little bit, makes it a little more radiopaque than the the lower part of the tooth. So again, here we have the septum, we have the foramen, have the, and we have the, and then here it's pretty hard to see, but there's a little bit of a change in contrast right through here. And so that is trying to highlight a lip line. That's really subtle though. What's that? This is the soft tissue of the lip, like the lip line. Because you can have, so typically if you see both of them, you'll see the nose is higher, like over the roots, and the lip will be closer to the crown. But you could get a nose that comes down farther than you might think just because of the vertical angulation of how they took the picture or because of the shape of their nose. But this one is the lip because it's so far down. So typically you'll see a nose somewhere in this region, typically. And then if it's farther down, like way lower on the crowns, it's more typically the lip. Here's an example of a nose and then a lip. Okay, so that's maxillary central incisor. So now if we take a canine shot, what would we typically see? So here we're going to see the floor of the nasal fossa. And notice that you see the floor of the nasal fossa over like usually starting about the canine and going anterior. So you don't see the floor of the nasal fossa in the posterior. Because in a canine shot, you see your canine is central and you usually see one or two of, you either see one or both of the premolars, right? So here you're going to see the floor of the nasal fossa, but if you look at what teeth are underneath it or, below that area, it's going to be the anterior teeth. It's not going to be the premolars. But what you do see over here on the side of the premolars, usually starting right about the distal portion of the canine and then going posterior, are the premolars. So now you see the maxillary sinus starting over the premolars, and you see the floor of the nasal fossa over the anterior teeth. So that's how you can know what's what, is you wouldn't label this part here. You wouldn't label this sinus, even if you're tempted to, because you think it looks like one continuous line. There, the sinus doesn't run in front of the central and lateral incisors. The sinuses run like canine and posterior. And then the other thing that you see oftentimes is a lateral fossa between the lateral and the canine. So the canine makes that canine eminence, and then it dips down and you have that lateral fossa. So that's a thinned out area of the bone between the lateral and the canine. So here we have the floor of the nasal fossa in the skull, and then the maxillary sinus coming down here over the posterior teeth, and then kind of a thinned out area between the lateral and the canine, which is the lateral fossa in the x-ray. It looks a little more radiolucent. Floor of the nasal fossa, and then starting about the canine and posterior, floor of the maxillary sinus. And we'll learn this in the next couple slides, but if you notice, you have this line that comes over here, and then the maxillary sinus that adjoins it, and they call this, the fossa and the maxillary sinus where they come together, they call it the inverted Y, because it looks just like an upside down Y. And so they come at this intersection, the nasal fossa and the maxillary sinus. So the floor of the nasal fossa and the maxillary sinus and the You can see the anterior nasal sinus, and then the inverted Y. Notice sinus is over the premolars, anterior or the nasal fossa is over the anterior teeth. Lateral fossa, and then lateral fossa. It's just more radiolucent in between the lateral and the canine. So what is this right here? Nasal fossa, yeah. What's this? There's sinus, and then can you see the inverted Y through here? It's like the tail of the Y and then the V of the Y. That's looking at it like a opposite, you know, the right side instead of the left side. So you've got to get used to kind of seeing the same picture, whether or not you're looking at the right side of the mouth or the left side of the mouth. Here's a couple more that are just taken kind of wonky. So things can look different depending on how the picture comes out. But if you kind of orient yourself and say, okay, so what tooth is this? Ventral incisor, lateral, canine. So what would this be? Your maxillary sinus, and what would that be? Anterior, yeah, nasal fossa. I don't know if I'm saying anterior nasal fossa. But when you first look at that, would that be kind of hard to pick up at first? Kind of weird looking, isn't it? It's kind of a wonky film. But if you say, okay, I'm looking at anterior teeth here, anterior teeth. So this radiolucency can't be a posterior maxillary sinus. It's got to be the nasal fossa. And then this is a canine. So that's going to be my sinus. So you kind of like do a little like critical thinking about the picture and what could possibly be in what area. So here's another one that's totally weird looking. They got a lot of vertical angulation. So what are these teeth here? These are your premolars. So then what does that make these red arrows pointing to? Right. And then this would be your nasal fossa. And here's your inverted Y, just kind of a little bit harder to see. Your inverted Y's there. Okay. A little harder to tell that that's a canine, but that's your lateral fossa. Everyone see that? Oh, yeah, question? So when you take your central incisor and you see the two radiolucent areas here and here, and the nasal, the septum and the spine, that's your nasal fossa. But then when you take a canine, you only see like half of it. So when you take a central, you see like the two fossas here and here, but then it changes the way it looks when you take your canine, because all of a sudden you're just looking at half of it and you're picking up some maxillary sinus. So you're getting, because your fossa is like in here, and so you're getting some of your fossa here and then some of your maxillary sinus here. The fossa, yeah, it's just the cavernous area. So it's like up in your skull though. So not your nostrils, but up the cavernous area that's up here. So it's just like, like with our sinuses, we have the cavernous, you know, just area that fills up with gunk when we're sick or whatever. So it's the same thing. It's just like hollow bone area. So now we'll move to maxillary premolar shot. So on a maxillary premolar shot, you're going to see the maxillary sinus, and then you're going to see the zygomatic process. So notice that the zygomatic process looks kind of like a swoosh. It's thicker and it's going to be more radiopaque and like bigger. So like a maxillary sinus floor is going to be thin, and it's just going to be kind of like this one thin line that goes along different areas in the around the molars and the premolars. But the zygomatic process is kind of going to swoop in over the molars, and it's going to look like a U, and it's going to be thicker and whiter. So we'll look at this a little bit more. On the skull, you have the maxillary process over here, and then the maxillary sinus comes through here. And then on this film here, you can see this thin line. This is the floor of the maxillary sinus as we come along. And then you can see a little bit thicker. This isn't a great picture. There's better pictures, but you can see how it gets thicker and whiter through here. And then that's the zygomatic process. And those better pictures. I'm not. Just to show you how it's more white and thick back here than it is here. So that's how you know the difference. This is a really good picture because you can really see, the process. It's a kind of a big U, and then you can see the body of it back here. All of this kind of white, it looks like a big swoosh. It's like your cheekbone, right? So you can see that whole area kind of picked up right through here, and it's kind of obscuring the apices of those roots there. That's the zygomatic process that kind of looks like a U or a J right through here, this thicker white. And then the floor of the sinus is thinner and right through here, and then kind of gets obscured by the process just because of the way that they took the picture. And these notes here say that especially when you do the bisecting technique, you pick up more of the process, probably because your vertical angulation is a little bit deeper. So then here's the maxillary sinus, and you can see the maxillary sinus comes all the way here and over here. And then here you can still see the zygomatic process to see it's a A or U shape. Maxillary sinus is dipped way low. So this is an example here, this maxillary sinus. This is an example if somebody wanted to have an implant done, they'd have to have what's called a sinus lift, and they lift the floor of the sinus. And so it's a procedure that they do, but you can see that if they wanted to put like something in here, they'd bust right into the sinus. The end of the implant would just be hanging out and like nothing. So they have to like go in and actually physically like punch up the sinus and like raise the roof on the sinus. Raise the roof. Isn't it funny that our palate is called the roof of the mouth and not the ceiling of the mouth? I don't know. I was just thinking about that the other day. It's like the roof is like up here, and that's like the ceiling. Anyways, beside the point. But so here's the zygomatic process again here and here. And then the thinner white line is your maxillary sinus. So now with a maxillary molar, you're going to see kind of a funny thing, because you can sometimes see a little bit of a mandibular landmark, which is the coronoid process. So the coronoid process is on your mandible. You have your condyle and your mandibular notch, and then your coronoid process. And sometimes when they take the picture of a maxillary molar, you get a little tiny snippet of the coronoid process down in that lower corner closest to your last molar. So it's not going to be over by the premolars, it's going to be over by the molars if you do see it. And it'll just be like the little end of the coronoid process. Then you have the maxillary tuberosity, which you can see here's a third molar. So it could be part of where the third molar, if it's unerupted, it could be kind of in that area. Or if there's no third molar there, it would just be that last bit of structure and bone that's behind the last molar. And then you can see the zygomatic process, and you can see the maxillary sinus. So they kind of photoshopped this in, but here's the coronoid process down in the bottom. There's the maxillary tuberosity. You have the maxillary sinus and the zygomatic process on the skull. And then here, you can't see the swoosh or the U very good, but this is where you have your zygomatic process, maxillary sinus, maxillary tuberosity. This is a tooth is what this is, but it's in that space where that third molar is. is your maxillary tuberosity. And then you have your coronoid process down in here. So it's going to peek in the bottom corner by the molars if it's there. Maxillary tuberosity again. Coronoid process, that's kind of photoshopped in, but there's a real x-ray with a coronoid process. There's a bunch of extra teeth, got a little baby wisdom tooth, and then they got another wisdom tooth. Here. And then here we have an image that shows a lot more of the body of the zygomatic, like the zygomatic bone, and then the process swoops over here. And we have the process here, zygomatic process here. You can see more of the body through here. You can see the maxillary tuberosity, actually. And then the coronoid process here, process, and then the maxillary sinus. The coronoid process looks lighter. Oh, maxillary tuberosity right through here. Yeah, it does look lighter. And there's the soft tissue. This is where their gum level is. The gingiva comes all the way to here. And then here you have their maxillary tuberosity. But yeah, it does look lighter right through there. And then you can also see some people have their roots, the apices of their roots are very close to their sinus. So that's why people get, if they have congestion or they have, sinus infection or something and they get a toothache, that's because that it's communicating so closely to the apices and the nerve in their tooth, and they feel that pressure. So they can get a toothache sometimes when they get sick. So that happens with people depending on how their anatomy is. Okay, so here we have the zygomatic process. You can see it's a thicker white line, more of a definite swoosh. And then you can see the maxillary sinus through here. This is the sinus space. So you might get a question that asks about the sinus space, which would look like the radiolucent area, like the cavernous area. Or if it asks for the floor of the sinus, that would be like the white, thin white line of the sinus. So sinus space or floor of the sinus would be two different things. And then this is a big old coronoid process right through here. This whole thing sticking in here in the corner, that's the coronoid process. And then this is the maxillary tuberosity through here. The coronoid process is this triangle of bone that's coming in through here, that part of the mandible. And so this is a lot in this picture, but sometimes it's just sticking out just a little bit. Sometimes you don't see it at all. It just depends on how far back and how, the patient's own anatomy and all of that. But if you do see it, it's like a little triangle of bone in the lower corner of the film closest to the molars. So now we'll go down to the mandibular images. So on the mandible, when you take a central incisor picture, you're going to see the mandibular fossa, perhaps. You don't always see it, but it's kind of more of like a thinned out area of the bone again. So it can look a little bit more radiolucent and sort of like an oval shape, sort of right around the central incisors of the mandible. And then the mental ridge, which kind of goes off from the center off at kind of an angle right below this central and lateral incisors. And it can look like a pretty defined line coming down, or you might not see it. I mean, again, it just depends on people's anatomy. And then the genial tubercles are sort of like a denser area of bone that's like a circle that goes around the lingual foramen. So the lingual foramen is going to be lucent because that's where you get some inner nerve exit or opening for the nerve, but the genial tubercles are kind of like beefed up bony area. I think it's some muscle attachments actually there, if I'm remembering correctly. But so it'll be more radiopaque around a radiolucent area. Your mental foramen is probably what you're thinking of, and that's on the outside, and that's where your mandibular canal or your mandibular nerve exits down here by the premolar, and we'll look at that in a minute. Did I say mandibular fossa? Oh, I'm so sorry. It's mental fossa. It's this, sorry. Yeah, no, it's mental fossa. Sorry about that. And I probably said mandibular. Did I say mandibular ridge too? Okay, yeah, it's mental fossa, mental ridge. So here on the skull, you can see the little hole there for the lingual foramen, and then you can sort of see like how it's like bumpy bone around it for the genial tubercles. And then it's sort of just a thinned out area of bone here for the mental fossa. It doesn't really seem like very much on the skull. And then this you can't see too terribly well either, but it kind of has a thicker ridge coming down on either side for the mental ridge. So here you can see the more radiopaque for the genial tubercles, and then the little radiolucency for the lingual foramen. Here you can see the mental ridge fairly good, right through here and here. And then the fossa would just be through here. It's a little more radiolucent there. Yeah, or did I hear somebody say something? Oh, okay. And then, so same thing here, genial tubercles, lingual foramen, and then here you can see that it's a portrait. If you're looking at something that's radiopaque in that area, it's going to be pointing to the genial tubercles. If it's a noticeable radiolucent, it'll be the fossa. Sometimes you can't see both. Sometimes you can see both. Sometimes you can only see one or the other. And then this is just a little anomaly. It's a bifurcated root on a canine. So that's just kind of a funny little extra fun thing to look at. And then mental ridge again, here and here on the skull. And then it's really obvious here. And then you can also see a good lingual foramen here. Can't really see a fossa very good, I don't think. This is a fossa. As you can see, it's a little bit darker right through here. So it's just the bone's a little thinner there. This is showing you the difference of what pathology looks like. So this is very circumscribed, light to dark, right around the apices. And we'll talk more about this in a few weeks, but so this is not mental fossa. This is some kind of infection. You see the difference there? Like when it's the fossa, it's kind of gradually goes from like radiopaque to radiolucent in the bone. It's not like this hard line of demarcation where you're like really dark, really good, healthy bone. So this is just to show that this is a definite different appearance than the fossa when there's actually some kind of infection going on. And then these little lines, all these little vertical lines coming down, so I think we can see these in the Dexter, I think, or there's some films that I've showed you guys where I've seen this, but these are nutrient canals. So you don't see this very often on people, but if you see little straight lines coming down off of the teeth, the apices of the roots, and those are nutrient canals. So the mandibular canine is going to show the inferior border of the mandible, which you can see sometimes if I back up to that one film here. This is the inferior border of the mandible. So this is just like soft tissue for the mouth, but this is the inferior border of the mandible as well. Don't always see it, but you can see it I guess maybe more often on a canine shot, I guess they're saying. So inferior border of the mandible, mental foramen, that's going to be the tail end of your mandibular canal is the mental foramen. You might see a little bit of the mental ridge, a little bit of the genial tubercles and lingual foramen. So here you have a little bit of the mental foramen there, a little bit of the ridge here, and then you can see canine is here. Those things off to the side because you're trying to center your canine, so it puts those other landmarks a little bit more off to the canine and your mental ridge where it looks a little more radiopaque. Canine and your lingual foramen and the genial tubercle. And your canine is here. Yeah. Yeah, your mental foramen is out here by between your premolars, and then your lingual foramen is on the inside below your central incisors. Your mental foramen, because when you do your injection, when you guys learn injections, one of your injections is a mental injection, and you go down right between your premolars on the outside in the vestibule. You just go straight down just a smidgy, and then you deposit, and then you put pressure and you kind of push the fluid into the mental foramen to get the anesthetic into that opening. And sometimes people can even push on the outside, right? You can sometimes find your mental foramen and push and actually get a little like tingly or numbness if you push really hard. Weird. So you know, and you just have it somewhere, who knows where it is, but it's somewhere around between your two premolars. But yeah, they're different landmarks. Yeah, one on each side. Yeah. No, you're good. Mental foramens, you have two of them. Lingual foramen, you have one. You only have one lingual foramen, and you have two mental foramens, left and right. So the blue arrow points to the mental foramen over here. You can kind of see it over here. It's kind of a weird place. A lot of times when you see the mental foramen, you'll see it more like here, or you could see it here, or you could see it here. That's kind of a weird picture. I would not use that one for an exam because to me that doesn't look super obvious. But and then you can see the inferior border of the mandible. And then here we have, so now for mandibular premolar, so the mental foramen next to your mandibular canal. Sometimes you can see some of the internal oblique ridge, which is also called the mylohyoid line. So you might see that interchangeable, internal oblique ridge or mylohyoid. And then your submandibular fossa, which some of this stuff you guys have been looking at on Canals. So Friday's group, you'll see more of this stuff, some of the stuff in Canals. So here we have the mental foramen here. This is kind of showing where the canal would be, somewhere in this area. The mylohyoid or the internal oblique ridge. And then the submandibular fossa, if you take your tongue and you kind of go to the floor of your mouth and then shove it to the right or the left, you can kind of feel how it kind of scoops in a little bit because you got a bunch of glands that nestle into that submandibular fossa. So a bunch of salivary glands that kind of go into there. And that's why you have kind of a scooped out area under there. So you got those glands in there. So the internal oblique ridge comes down through here. It'll look a little more radiopaque, and generally it runs across the roots of the molars. So if you can see it, it's usually about halfway over the roots of the molars, and it's more radiopaque. And then you see the submandibular fossa is more of a radiolucent area. Usually looks kind of like an oval area. And it's right around the roots as well of the molars. So then the canal and the submandibular fossa can get a little bit confusing because they're in the same area, but the fossa is generally much larger and it can kind of obscure the canal. So sometimes what will happen is you'll see the canal, especially in a pano, you might see the canal coming down and then you kind of lose it a little bit in the fossa. But with a PA, because the detail is better, then sometimes you can still see the walls of the canal in the fossa. So here you can kind of pick up a little bit of the walls of the canal through here. And this one, again, I don't love because this is either a ginormous canal or it's just not actually highlighting it. Because there's a lot of distortion in this picture. There's a lot of vertical angulation. See how much of the crown. So this might be making the canal look much bigger than it actually is. So I probably wouldn't use this one. What is these notes? Maybe I should read these notes. Runs down from mandible is below the internal bridge. Yeah, I do think they're pointing to this thinner white line as being the wall of the canal, which makes sense. So then the submandibular gland fossa is going to be a larger area, and it's generally kind of looks a little ovular, sort of, and it hangs out somewhere below the roots or sometimes even over the roots. It depends on the person's anatomy. You can see how it's just thinned out through here, and so it's going to look more radiopaque through the X-ray. So we have the mental foramen. So this one, I think this is their premolar turned. And I guess it could be the first molar, but it looks to me like a turned. But anyways, typically see how this one is like in between the roots of the premolars, but notice also how this one is really close to the apice of the second premolar. So if you don't know your anatomy and you don't know what to expect to see, you might be like, oh my gosh, they have an abscess. And no, it's like, no, this is the mental foramen. So it can be tricky. So that's why this one is so important to kind of like know exactly what you're looking at. Time to get out. Oh my God. I have the softest, quietest alarm, and because I wake up so easy, so I don't need like a wah, wah. That would give me a heart attack. But so I just have like these chimes. They're so quiet, and I wake up like every time. Okay, let's take a little break. So here we are. We did that already. All right, there we go. Okay, mandibular molar. So on a mandibular molar, you're going to see the external oblique ridge. You're going to see the internal oblique ridge, submandibular fossa, and mandibular canal, maybe the mental foramen, maybe. So a lot of these, you just see them from different perspectives. You might see more or less of them depending on if you're looking at a premolar shot or a molar shot. So here we have the mandibular canal that will run through the middle of the mandible and up the halfway up the ramus, sort of. And then you have the external oblique ridge. You have the internal oblique ridge, which comes down lower and below the external, and it runs in front of apices or the roots. And then you have the scooped out part, which is your submandibular fossa. So here you have the external oblique ridge. I always say kind of like on the piano, just think about it kind of coming off of the back of like right about the CEJ-ish, depending on if they have bone loss and things like that, right about there, and then straight off the back. That's your external oblique. Sometimes you can see it kind of connect off of it, sort of, it almost looks like it, and then run in front for the internal oblique. But this is pointing at it kind of in a different, it looks a little different in this one, but it's just the top of this radiolucent area where it's a little more radiopaque running right across the roots. And then D is the submandibular fossa, which is just kind of this larger radiolucent area. And then you can see the thin, faint white lines of the walls of the mandibular canal. You can see them inside that fossa. They run up and down like this. So that's the mandibular canal. So here again, you have the external oblique bridge and then the internal. Internal, thicker, white, a little bit whiter. And the thin white lines of the walls of the canal. So the nerve runs through the center, and then the white lines are the wall tube or the canal. And then what does it say about the mandibular foramen at the top and the mental foramens at the end? So when you're giving an injection, when you're giving an IA, you're trying to get toward that top part of the opening of the mandibular canal. That's what you're shooting for when you're giving local anesthetic, so that it can run down the whole canal and numb up that whole side of the jaw. You don't look, the mandibular foramen, it's just talking about it, but I don't know that you necessarily see it. I don't think it's like a landmark, but the mental foramen you definitely see. You see that. The mental foramen is up high at the beginning of the canal, and then the mandibular canal runs down to the mental foramen, which is where the other opening is. And then the lingual foramen. So submandibular fossa, depression on the lingual side of the mandible, below the mylohyoid or the internal oblique ridge, or the internal submandibular gland is located in this region. So, and the depression, we've seen that a lot. This is your internal oblique or your mylohyoid. I don't know why we jump around the two different terms. That's kind of confusing, but they are the same thing. External up at the top, coming right off the back of the tooth, and then internal dropping down a little bit lower, and then right above the submandibular fossa. You can kind of think about it stacked: external, internal, submandibular fossa. And then in the middle of the submandibular fossa is they're the same. Is the external called the mylohyoid? Not in our class. I don't know. It might be, yeah. Yeah, different muscles on the floor of that's a good question for your dental anatomy teacher. Ask her, she'll be brushed up on that stuff. But yeah, I mean, good guess. Maybe we can research it and get the answer real quick. My other class, my special needs class, someone is inevitably asking me something that's not in our deck of information that we need to learn. And so then I'm like, and then they Google it, then we find out. So that's always more than welcome. Okay. So mandibular canal, the red arrow, identify the inferior border of the canal, usually runs very close to the roots of the teeth. This is kind of interesting. Those are some impacted molars. I know, like, wee, it's like, look how cute I am. It's like little kicked up itself, but so funny. Dilacerated root. Okay. So what do we call this? Nasofossa. Good job. What do we call this? Tuberosity. That's right. What do we call this guy? Coronoid process. Coronoid, close. You knew the area. Coronoid process. What do we call this? Zygomatic process. What do we call this radiolucent area? Lingual foramen. Good job. What do we call this radiopaque line here? Mylohyoid or internal oblique. What about this? Submandibular fossa, yeah. So the canal is going to be a little more defined. So the big difference, the canal can run through the fossa, but the fossa is going to look kind of bigger and more radiolucent, and then you'll usually see thin lines of the canal running through it, or sometimes it's obscured, and you'll see it kind of before and after. This down here, no, it could be like if this is a traditional film, it could be a dot artifact. Maybe if this, I don't know if this is a digital film or a traditional film, but because that wouldn't be, the mental foramen would be way over here, not the lingual foramen, because that's the posterior teeth. So it could be a dot artifact. A good question. Good eye. Okay, yellow arrow pointing to what? Zygomatic process. Red arrow pointing. Maxillary sinus. Orange arrow. Septum. Turquoise arrow. Suture. Yep, good job. Median palatine suture. But it's the red arrows pointing to. Mental ridge. Yep, good job. And oh, here, I'll go back. Mental ridge. So that little kind of like the bone's a little bit thicker and it kind of runs down this way right in front of the anterior central and laterals. And it runs down like that. So this one, it's kind of a funny angle, but it's probably not a great picture for that. But and then now what's this kind of sandwiching in here? The canal. Good. So you see here's your fossa, bigger space, and then you can see your canal inside of it. Okay, dental materials. So it says game, but I'm just going to tell you what we're looking at because we haven't really practiced it yet. So how can you play a game? Although feel free, I'll just ask you guys. Let's see how much time we have. 20 minutes. So I'll ask you guys if anyone knows it first, and then I'll tell you what it is. Okay, so what's the red arrow pointing to? Amalgam, yeah. So amalgam's always going to look kind of bunchy. It's not going to look real like nicely carved. It's going to look kind of bunchy and have kind of odd margins. And then it's going to be very bright white. Yeah, it's got some overhangs through here. So this is like a MO, like an MO, or I don't know if it comes off the buccal or lingual, but it doesn't go off the distal. So it's like an MO, and there's like an MO meaning mesial occlusal restoration, and it doesn't have a nice transition. So this is an area that they could retain plaque, and the gums could get inflamed there. They could get recurrent decay eventually because it's got this overhang here. Okay, so what's number 2 pointing at? Yeah, it does look like some more amalgam. All these look like amalgam through here. And then what about number 3? A PFM. Yep. So this is porcelain fused to metal. So the reason you can tell that this is a porcelain fused to metal is that it has this very nice, smooth, kind of prepped core. So this is nice and prepped here. And then on the outside, you have porcelain that's been fused to a metal kind of, crown or like little prepped area. And so that's why they call it porcelain fused to metal, PFM. And then the rest of those look like. That was just more amalgam. And then what do you guys think this is? They look like cavities, don't they? But this is actually really old composite that you probably won't, unless you're seeing a patient that's significantly older, you probably won't see this at all. Nobody would get this done probably now, because now they make the composite with material in it so that it's more radiopaque. But you can see the liner. So they did their prep, and then they put liner here, so some kind of a more radiopaque liner, and then they filled the rest of the area with a radiolucent composite that doesn't even show up. So it's a very kind of old style. So you won't see it. The material that they use nowadays is much better. But it's possible that you could see that. So we just keep it in there. Okay, so what is number 5? A pin, that's right. And then what's number 6? What kind of crown? Gold, yeah. You guys, it could have been a game. Lots of you know what all these pictures are. So this is a full gold crown, and you can tell it looks nice and smooth. They all are full gold crowns. They look nice and smooth. The margins are nice. So clearly it's not something that was like formed freehand. Okay, what's number 7? I think I heard someone say full porcelain crown. So this is a porcelain inside portion and then a full porcelain outside, full porcelain crown. So this might have been made maybe on like on a CEREC or a E40 or something like that. I'm not sure. It's all porcelain, just all porcelain, full, they call it full porcelain crown. Or a ceramic, sometimes they call it a ceramic crown. So they have these machines, but one is called like CEREC. There's another one called E4D, and there's probably other ones now. Those are the ones that when I worked in practice, the doctors I worked for had those different machines, and they do a bunch of scanning in your mouth, and then they mill it right there in the office. They take a little block of ceramic material, and they mill it and like shave it into the shape of the tooth, and they're called like same day crowns. But the office that I worked at, it took so much time to scan the person's mouth and do it that oftentimes they still made it a 2-part process. I don't know if anyone who's assisted worked with literal same day crowns. They definitely do them, but the office I worked at, the doctor just hated being rushed. So they just would scan it and then have the patient come back like in a couple of days or something. Okay, what's number 8? It's stainless steel, so close. It's like you were thinking along the same lines. It's not as dense as like a full gold. So it's thinner, so it's a little more translucent, and the margin is pretty bad. So this is usually on kids. Some adults can have a stainless steel, temporary crown. That's pretty much, it's supposed to be temporary, but I've seen some adults not come back and they're like, that's fine, and then they don't want to get it. So, but usually this is something that's typically done more on primary teeth, and then they'll get a more permanent one when they are a little bit older. And then what about number 9? Orthodontic bracket. So see how it doesn't really have like a top so much. It just kind of looks like it's a band around it. So that's an orthodontic bracket. What about 10? Denture, yes, you guys saw that before. Ghost teeth floating there. What about 11? Yeah, it's a wire. For some reason, they have this in their mouth. If they, maybe something is not just a regular suture, because sutures are usually made of like, you know, either they're like resorbable, like cat gut or something, or, but they're not metal. So this is some kind of a wire for some reason. I don't know. They had some kind of a surgery or something. Maybe their jaw broke and they, you know, have a wire. We don't know. It's a mystery. What about 12? Huh? Yeah, 12's composite. Good. So it looks a little bit more not as radiopaque as the amalgam. So that's a composite. And then what about this down here? I heard it, amalgam tattoo. So little fragments, little dust fragments of amalgam that embed in the tissue. And that's the amalgam tattoo. And so it usually looks kind of blue gray if you can see it. And sometimes you don't see it, but you just see it on an x-ray. So it depends on like how close to the surface it is. Not really. I mean, I guess they could kind of work their way, you know how splinters work their way to the surface. So I guess they could, but a lot of times, no, people just have it there and it just hangs out. I think it could, I don't know if that discoloration is like actually the cellular changes, or if it's like I think as long as the amalgam is in there, it causes that coloration. Yeah. That's like a buccal or a lingual amalgam. So that's like a buccal pit or a lingual pit. Mm-hmm. Okay, so what about 14? I heard, yeah, a post, yeah. And then this is a bridge. Yeah, I heard someone else say, oh yeah, 3-unit bridge, same as down here. 3-unit bridge and a post. Well, I think just this, I actually did make some practice stuff. I could see if I have it pulled up so you guys can like different images. Yeah, so this is a root canal. This is a root canal here as well. And we'll see what this is. What do you guys know what material they put into a root canal? Gutta percha. So the gutta percha is not as radiopaque. A metal post or pins, they'll look more, you know, like radiopaque. But we'll get to that gutta percha in a second for the root canal. What about this? What's this? Space maintainer, good. So that's like an ortho thing, space maintainer. Or sometimes they put them in adults, like if an adult lost a tooth and they know they want to have an implant, you know, your teeth will just kind of sort of collapse. If you take out a tooth and they'll just kind of fall over time. So sometimes they'll support them and put in a space maintainer, but usually they do that with kids, because kids are the ones that might lose something prematurely, exfoliate teeth in funny times. And so, but this kind of looks to me like an older mouth for some reason, just because the amount of work. What about this little thing? What could that be? It is, it's the tip of an instrument. Don't do this, you guys. So when your instruments get thinner and thinner, and you're sharpening them and they get thinner and thinner, if you're root planing and somebody has heavy calculus, or you just have a heavy hand or something, you could break off the tip down below the gum line. And usually I've done it before myself, and usually it's not a big deal, because we have these little retrievers, little magnetic retrievers, and you can, and I've never broken it so far that I couldn't actually even see it in the sulcus. I was kind of like, oh, and sometimes I did it like 2 or 3 times when I was in perio practice, because it's hard. Your instruments get thin and your doctors don't always like to buy you new ones. And so you use thinner material. We're very, very, very picky in our clinic. Like they will retire instruments that I would have used far longer in real practice, but we like to eliminate risk at every turn that we possibly can. So when an instrument starts to get thin, usually people are taking it out of your hand and going, no, you cannot use that. But there's ways you can use a little magnetic retriever. Worst case scenario, someone might have to have their tissue flapped back in surgery, but that's not as likely to happen as much as being able to just take it out with the little magnet thing. I don't know who was first, Brendan. I think Brendan's hand was up first. You say, I just broke my instrument tip off in here. Oops, it's okay. You can actually not tell them anything and try and fix it. Like go get your instructor, go get the magnetic retriever. I don't know what it's called. It's a magnetic, it's like a shape like an instrument, but it's a magnet, and try and get it. Don't go in with another instrument digging around. Just get your instructor and get the little thing. If it's not easily taken out, you'll go get an x-ray, try and locate it, and the instructor will probably try and take it out. And if all of that fails, then you say the instructor will probably help you tell your patient we broke off a tip. I've never seen it get to that point though. It honestly is usually not nearly that involved. It's usually like, yeah, well, it's usually embedded in the sulcus. But yes, Liddy. Oh yeah. Oh yeah. Probably, but it depends on how much like perio patients you see and how thin you let your instruments get. Because instruments are very hardy and they don't break off that easily unless they get really thin and you can literally see the toes kind of bent, like you can see the flex. And if you'll learn more and more as you use your instruments and as you understand like how much pressure something can take, you'll be like, I am probably like pushing it here. I probably should not, because skinny instruments are fabulous for getting into tight fibrotic tissue and getting down into a deep pocket. They're wonderful. So you want to have some thinner instruments, but you just want to know like, this is kind of being a cowboy or whatever. I probably shouldn't do this. And this is safe and probably okay for me to do. And then you have these things like the little magnetic retriever. So this one to me, like this, their bone levels here. I bet you anything their tissue is here. So, and maybe they have, their tissue looks like it here, but it could be lower, they could have more recession. So this could literally be only a couple millimeters below the gum line. So it's not like it's like, way down there. Even though it looks like it is, they have a lot of bone loss. And so their tissue is at the highest height, it's here, but it could be lower either on the front or the back. So yeah, go find a dentist that buys you, instruments that stay sharp or that don't get whittled down. I sharpened a lot because a sharp instrument cleans it's less fatiguing on your hands. It cleans better. So I was like, they needed to be sharp. And so I sharpened some of them probably way too thin. And then but it happened to me a couple of times, but it never turned into a big deal. I was always like, oh no. And then I got it out like right away. I was like, oh, good. Very good. So, but then I have asked Gail, she's probably done it too. No, they can't. They don't know. They don't even know. Half the time, the only time it's ever happened was when I was group planning and they're numb anyways. So they don't, but even if they weren't numb, it wouldn't hurt. They wouldn't know. Okay, so what is this? A post. Yes, good. A post for a root canal. And then opposed to this. At a percha. You can kind of see it pooched out the bottom of you can, spell it. I thought you said smell it. And I was like, smell? I don't know. Gutta, see, it's G-U-T-T-A, gutta, P-E-R-C-H-A. It's to fill a root canal. So they'll remount the canal, and then they'll fill it with gutta percha. And you can see the periapical radiolucency right through here. So this is either a failed root canal or they just did the root canal. So they might have just done it. And this will fill in hopefully with bone, or it's a, yeah, either a brand new root canal or it's failed root canal. I'm not sure which one. But I'm assuming they just did it because typically they would then put a crown on. A root canal tooth is more brittle, so usually they put a crown on a tooth after they do a root canal. And then here's some, what's this, all this speckly, floaty stuff. Yep, amalgam fragments in the gum tissue. And then what do we see in 21? Gutta percha. And then 22. Yep, post, and 23. PFM. You guys have this down. It's just the I don't think the post is broken. I mean, I'm not an endodontist, so I don't exactly know, but it just looks to me like it's two parts that they just put in two parts. This might be the post to, sometimes they have to do a build-up. So they have to do a post to build up like a core to put a crown on. So they need to like put a bunch of stuff. But a lot of times when they do that, these teeth are very, you know, like the more nails you put in a piece of wood, the weaker the wood is. You just keep putting nails in it and nails in it. Now it's full of, even though you got all these nails in it, it's kind of full of holes. And so, and then the tooth itself becomes more fragile and brittle. And so a lot of times nowadays, when something needs this much work, doctors usually offer implants. And they're like, you don't want an implant, which is what this is over here, is an implant. So we have a titanium screw, and usually there's an abutment right through here, and then porcelain fused to metal crown. Yeah, Paula. Implants? Like, you mean like in restorative class, or? So I guess I'm kind of not entirely sure what you're asking.
Is there where PowerPoint? It's on here. I'm sorry.
So in order to learn this information, you just need to look at the pictures that I've been showing you. I feel bad because I want to actually know what more, like, do you want like amalgam equals radiopaque? Do you want me to write out something?
Yeah, I don't know.
Yeah. Yeah, I can get a document together where I describe it, but I think, why is everybody leaving?
You still have 2 minutes.
You still have 2 minutes, and I'm trying to answer somebody's question. So thank you. So I can write a document for you that says like amalgam filling, this is what it looks like, and I can go down. But honestly, the best thing that you can do is memorize what it looks like on a radiograph, because you guys are going to have restorative where you're going to learn more about these, but in order to recognize it on a film, you just need to look at pictures of it. But I will do that quickly because we are, that was the last one, but yeah. It probably does. I haven't looked at the textbook this week, but it's probably very likely. So look at the reading, perhaps that could help. Yeah, Maria, go ahead. Yes, it's going to be literally like this. You're going to see a picture and I'll say, what is the arrow pointing to? And then you'll say amalgam. It'll be literally like that. It might be multiple choice, or if it's the landmark exam will be fill in the blanks. Yeah. Okay, now you guys are done. Bye. It's going to be on the exam. Yeah, just the dental materials.
Oh,
Not the anatomy. Oh, yeah, the anatomy won't be, that's going to be on the landmark exam, but exam number 2 will have dental materials.